All right. If you don't know who I am, my father and I did the first meetings of specialists from all over the world that we could find over almost 15 years ago in cosmetic gynecology. And the very few that were doing them had been doing them for a while. Some of them have been trained by Dr. Matlock. Some of them had been basically trained on their own. Just figuring out procedures to make women's sexual issues better, to cover things that weren't being covered in regular medicine, in regular training programs, in regular specialties. So we came out with the term cosmetogynecology 20 years ago to describe this. But to us, it was more than this. It was the total aesthetic treatment of the woman, which extended into the traditional aesthetic procedures of the body, the breast. So to us, cosmetogynecology was always about more than just the vaginal, the genital area. It was always the whole body. But being gynecologists, most people that we worked with weren't too comfortable outside of procedures, except for maybe liposuction and procedures like that. But that's how we started. But the majority of the gynecologists that come in want to focus on the genital issues, and that's fine. But you're going to get perspectives from outside of that are going to help you to do better work from doctors that approach things slightly differently. So this is the 13th year that we've been giving programs. We established the ISCG in 2004 and started giving programs annually and world congresses annually. And this is our 10th. This is a milestone for us, a 10th World Congress. And it's nice to see that the first few was people that we were training. So we were the experts and nobody else was an expert. And if we didn't know it, well, you know, maybe somebody will help figure it out for us. But now it's nice to see we're into like 2 or 3 generations of cosmetogynecologists and specialists from other specialties that like what we're doing and have things to offer to us, and we have things to offer to them. And now we have the whole world here in this room. And some really groundbreaking stuff happening independent of our original work. So we're everywhere. The cosmetogynecologists have started societies in their countries. You know, some as recently as a couple of weeks ago. So some of the trends that we see in the specialty right now, or the subspecialty, whatever you want to call it, is that we are blurring the margin between aesthetic and therapeutic quite rapidly. What started out as platelet-rich plasma is good for fat transfer has become, as platelet-rich plasma has factors which are good for healing. And once it's something about healing, it's about all of medicine. And then once people say, well, these factors work on stem cells, and people start integrating what they know about the stem cells, we're everywhere. And we bring in specialists who know more about stem cells that have been studying it for years in the laboratories. So now we're branching over. So when you have a patient with an issue, you can approach it with aesthetic technologies to do therapeutics. So this is something that's brand new, but this is what's going to push it over the edge into legitimacy. So this is hot. Platelet-rich plasma right now is something that everybody is doing. We have some of the leaders in the world in the PRP business in this room right now. I just met for the first time Dr. Runnels in the back, who is the vampire lift and the O-shot genius. We've got Dr. Zocchi from Italy, who is one of the pioneers in stem cell therapy. He's going to lecture us tomorrow. And if you don't know who he is, okay, you're not going to forget who he is after this meeting. They're doing phenomenal work with things that you would have said, how can we fix this? This is unfixable. And they say, wait, we have something for you. And this is the new buzzword coming out of Europe. It's called translational medicine. If you're unaware of translational medicine, you can jump onto your YouTube and your Google right now and get some background on it. But basically, they wanted to create communication between basic scientists, patients, and specialists all at the same time. So an integration of development. So if there's a laboratory finding that has relevance in a clinical setting, you don't have to go through years and years of pharmaceutical research to get this product out into a clinical trial. You can do it much more on a granular level, much more quickly with the help of modern technologies, modern communication. So the field of translational medicine is something you're going to be hearing more and more about everywhere. And this is the future. So, you know, if we find that in a certain micro branch of some surgical specialty, people are getting good results in healing, okay, that goes back to the basic scientist who says, how can we adjust this quickly and make modifications during a trial? We've got the rise of the machines. There was a movie about this. It used to be, okay, if you didn't know how to operate, you really couldn't help a woman for laxity issues. And there wasn't much more than, you know, your usual. Take a hormone or, you know, a little lubrication. But this is changing. And the machines are proliferating very, very rapidly right now. What this is doing is it's making it accessible to doctors who don't know the surgery. Okay? You know, some people look down on people as you're a machine owner. Well, if that machine owner was the only person who could help the community, what's wrong with that? Nothing. Nothing wrong with that at all. So this is pushing the aesthetic, even some of the therapeutics now, into specialties that weren't our own. So now it's not unusual to have a non-gynecologist treating gynecologic issues. But then with the good, there's the bad. Okay, if you don't know what you're treating and you're just sort of shooting a machine, maybe you're missing something. Okay, maybe it's the right thing, but maybe it's in the wrong sequence. Maybe you should have done something else first for efficiency's sake. So this brings me to just a brief touch on the small problems that I see with this. Okay, a lot of the new technologies are driven by patient reviews. Okay, how did you think the procedure went? And the patient's whole critique of the procedure goes into what the waiting room looked like, whether they had coffee, if there was a parking space, how long did I have to wait? Had nothing to do with the technology. It was just about the experience, just like when they ask you to rate the hotel when you get home. Okay, you know, really, what were you trying to get out of it? It wasn't about the parking space. So when you have 5-star ratings for parking spaces and coffee, you're really not rating the technology. And it's good for selling it. It's good for marketing it to get patients into your office. But to answer the good question is, does this thing work? It's not answering anything. So this is not data. Unfortunately, you know, all these machine companies are in a business. Their job is to sell the machines. Okay? Your job is to find out what they do with these machines so that people will want to buy them. Okay? Nothing wrong with that either. Okay? They paid for a lot of your trips to come here and talk. But if the machines don't work, sooner or later, people will stop buying them, and people will stop trusting the doctors that are using them. And you don't want that to happen. Nobody wants that to happen. So we need real data. And, you know, we have people here with clinical backgrounds. We have the translational medicine rise, all making it easier to study these things. And we should be studying these things. Doctors who have no background in aesthetics are getting into aesthetic treatments because the machines can do the aesthetic treatments. So if I buy a laser, an expensive laser, I want to use that laser, not to pay for the laser. And second, why did I buy it in the first place? To use it. So some of the flashy numbers that you see about, oh no, you can make X number of dollars with this procedure if you just multiply out the number of procedures. You need a background in aesthetics to have those discussions with the patients. If I sell you a $3,000 treatment for urinary incontinence and your insurance covered something for free and the incontinence treatment didn't work, okay, how do you think your next discussion with the patient is going to go? That's going to be a difficult talk. Doctor, you talked me into this. I've got $3,000 less and I'm leaking still. What have you done for me? You know, she will tell her friend on social media. They'll tell the entire country. So, you know, you need some kind of a background in how to manage expectations, how to set the expectations, and how to really understand what the status of the technologies is right now. I mean, it's some really cool technology coming out. You're going to see this in this meeting. If you're not a gynecologist, you need a little background in gynecology to be treating incontinence, to be treating laxity issues. So you're sure that it's an incontinence or a laxity issue you're treating and not something else that you missed. And of course, if we make mistakes, okay, the people who thought we were crazy are going to say that's the evidence that we're crazy. If we fight tooth and nail to get one paper published in a regular journal or in a regular meeting to get something presented, and then some non-informed person goes off and starts charging $3,000 for incontinence procedure and having horrible results, that's what they use to tell you that you don't know what you're doing. And that's something you have to be aware of. So you don't want the academics to be controlling the standards. You need to control the standards. You need to be the police for the people that should know a little bit better by education. Okay, I wanted to touch a little bit on the innovation cycle because it's very relevant to everything that's coming out right now. Okay, innovation is something that fixes a problem or that meets a need that wasn't met before. And that was the original reason why there was a big spike in vaginoplasty, in labiaplasty, in all of these cosmetic procedures. Because there was a latent need. It had nothing to do with porn. It had nothing to do with the media. People wanted these things fixed, but they didn't know they could be fixed. Once you know you can fix something, you'll get it fixed, right? Like if you knew your testosterone goes down and you can replace that, would you replace it? A lot of people do. If you didn't know you could fix it. So this is how innovation goes. You have your innovators and you have your early adopters. That's everybody in this room, okay? Then you have, well, we put ACOG, the pragmatist. They won't make a move until they see real data. You can throw them all the 5-star reviews you want, okay? You can show them all the flashy pictures. They're going to stand there and say, doctor, show me the science. And they're not going to budge until they see that science. So what you have to do to break over from the early adopter to the early majority, which is most of the people that are against these procedures, is to solve problems that they can't solve. If you solve little problems, when they're desperate, they're going to be forced to use your solution because they don't have an option, okay? Now, I see this war being won in lichen sclerosis, and you're going to see how these people are doing amazing things with lichen, which, you open a book, give them a steroid, pat them on the back, okay? If it doesn't work, a little lube, do it again. And if it doesn't work, you keep doing it again, until they find somebody else who solves the problem. Well, after a while, and after everything is out in the open, these problems are being solved, they're going to listen. So once they trust you for one little problem, they'll trust you for the next one, and then the next one. And that's how innovation gets adopted. So your typical early adopter has nothing in common with your typical ACOG person, okay? They're usually, they're either hustlers, smart people, but they have a higher level of risk tolerance, okay? You know something might not work, but you want to see if it works, so you take the leap, okay? Now, the early adopter comes in a few different flavors, okay? There's somebody that's going to repeat what you taught them and do it well, okay? And that's one early adopter. The first one in his town doing these procedures, the first woman in the town doing these procedures. Then there's a creative early adopter who says, I'm going to take that procedure and make it better, okay? A lot of people we know. And then there's the one that's going to take it the wrong way, and I call it the perversion, and start using it for things that don't make any sense just to do it. So these are the things that you see with these technologies. And the elaborators and the repeaters are the ones that are going to be giving you the real data. The pragmatists sort of don't want to take any chances. And like I said, they want to be shown the data. Show me that these things work. Okay. So some of the problems we need to control are the ridiculous claim people. Okay. You need to control these because the academics are going to use these people against you. They're going to say you and them are the same people. The bad result people, the people that don't understand the market and have just bad interactions with patients. Give me $3,000, I'll fix your problem. Does it work? Every time. Okay, that kind of stuff. Or they just don't understand the technology, and they'll hurt somebody. Okay, one of the key issues in a non-cosmetically experienced person is over-promising and giving the market pitches as the expected results and then not delivering. Okay. The other one, a false sense of confidence that this is going to fix everything. And so you start talking very confident, and then the result doesn't match the confidence. And then there's the shotgun mentality. Okay? We're just going to give you 10 different things, and one of those 10 is going to work. Okay? Well, how are you going to know which one worked? If you need to adjust it, how are you going to adjust it? It doesn't work very well. And then you have the hammer. Okay? You have a machine that fixes everything. Okay? Now, there are some machines that fix a lot of things, but they don't fix everything. And they may not fix it as well as some other things. So maybe at a different stage in the process, you might have to change your hammer. So our goal is to have people embrace and adopt our way of thinking. Okay? The key to getting this to widespread is to convince the pragmatists. And the only way to convince them is with data. So our solutions. First, silence the pragmatists. Solve those little problems using aesthetic technologies. Okay. Make strong science and make the follow-up. It wasn't 48 hours. Look, it looks good at 48 hours. Look, I cured incontinence at 10 days. Okay. I can do that too with anything. All right. And, embrace the cross specialists. Not all the plastics are against us. Okay. It's just the official ones in their version of ACOG. They're just trying to protect their people. Okay? And then the pretenders. Okay? If somebody is doing something that doesn't meet the standards, you be tough. You just show them. Tell them, what you're doing is wrong. Your claims are wrong. Your results are bad because you're doing things wrong, not because there's anything wrong with what you were trying to do. So, as the experts, this is your job. Okay? You're going to control your specialty, and it's going to grow perfectly. All right. And this is my little ending slide. Just remember, pat on the back is only 18 inches from a kick in the behind. Thank you.